Awesome. Okay, thanks for having me. Thanks for staying. They've put the statistician on last, which probably isn't a good way to wake people up. Okay, so I'm a PhD student at the University of Sydney. My PhD topic is on measuring the do not do recommendations or low value care in routinely collected data, particularly private health insurance. So today I'm just going to share some insights and tips that I've discovered along the way in case you're doing any measurement work yourself or you'd like to talk to me about it later. So we're all familiar with the atlas and the insights that we get from geographic measures of variation in healthcare services. But the issue with this is that it's an indirect measure. So our work focuses on direct measures of care, which is where we're trying to apply a binary criteria of whether something was inappropriate or appropriate based on the clinical information that's in the data sets. So whereas the geographial measures are just like a service count that's usually adjusted for area or some other indications. So what results do we get? Well, high variation in a geographical measure may mean underuse or overuse of services. And if there's no variation, then we just know that there's no correlation between the area and the service use. We don't know if it's actually inappropriate or appropriate. What's the right level of care that should be happening? Where direct measures, we get the specific count, and we can actually say what's underuse and what's overuse. And finally, the conclusions, we get the variation in service utilization exists. Okay, we see that on the map. Whereas in the direct measures, we get the actual answer of X% of services were low value or Y% of patients had low value care. So there's a few other issues with direct measurement, one being that you're sort of limited in the number of services you can look at, right? Because you're limited by the clinical information that's in the data set. The other issue or opportunity is what denominator do you actually choose? So these are some examples from Choosing Wisely Australia, where we've got the patient description or indication of what is appropriate or inappropriate. And then we've also got the actual service description in orange there. So if we were to take these and think about how we would measure them and what results we would report, you've basically got three options. So the first we've classified in a group of two that we've labelled as patient-centric. So we select for the denominator, we select either all patients with a specific indication in the recommendation. We can select all patients in the entire cohort, so whatever data set you have or population that you're looking at. And finally, we've also got the service-centric measure, which is whatever patients or admissions you have with the specific service from the low value care recommendation. And then of course the numerator is the actual group that received the low value service with the low value indication. And then our findings is just the percentage that falls out. So it's actually really straightforward, but when you look at the literature, you'll see like a huge range of what people are actually reporting. So I think it's really important to get a grasp of it when you're reading this sort of literature and starting to do your own. So this is an example from the States where they looked at a US and Canadian Choosing Wisely recommendation on carotid ultrasound imaging for syncope patients. And so it was in the US Medicare data set, the 5% sample, they had 1.3 million beneficiaries altogether. And we see that if we say, okay, how many patients had the carotid ultrasound and syncope out of that cohort, it only affected about 0.7 or about 1% of patients altogether. So it's not a very high volume, low value care, but then when we think about, okay, for the patients that present with syncope, about 16% of them have the service, so that looks like an area of concern. And again, with the percent of our carotid ultrasounds that they were using, about 6% of patients of those ultrasounds were low value. So perhaps not as concerning as what it looks like from the patient perspective, but it's still not zero. So why consider all these different types of measures when you're looking at these studies? Well, one is that to get a complete picture of what our low value care measures look like, sometimes we need to look at all three. So the knee arthroscopy for patients with osteoarthritis, which you've heard a bit about today, is a good example. So these were numbers taken from different studies, so they're not in the same populations, but it gives you an idea of what it would look like if they were in the same populations. So our knee arthroscopy, we've got over 60% of arthroscopy services performed on patients with osteoarthritis. So that's might be an indication of the percentage of low value care. We then have, looking from the patient perspective, only 4% of osteoarthritis patients go on to receive an arthroscopy. So looking at all three sort of gives you an idea of where we should target and whether it's the specialists that we should talk to that are performing the arthroscopies here. Another reason is that if you change what your predictor of low value care that you're examining is that you might get different results depending on which denominator you choose. So this is an example where they looked at another popular example of imaging for patients with low back pain. And they compared a private payer, again in the States, to Medicare. So the percentage of services that was low value was the same in both the private and Medicare group. But then when they looked at the percentage of patients with low back pain, they found that it was 20% higher for one payer and not the other. So if you only look at one certain perspective in your measurement, you're going to be missing out on insights that are actually really valuable. And finally, there's different audiences for these types of results. So first off, we've got the sort of clinical decisions that comes down to what group of patients you're focusing on. So this is where you should probably apply your PC indication measure, because this is the group of patients that have the potential to receive the inappropriate care. The next is the PC all, which people sort of report quite frequently, but it looks quite strange because they're always very small numbers because you've got such a large population in the denominator. But it's actually useful when you're looking at a range of low value services because you can see what the largest volume is of inappropriate care. So we classify that as a sort of like a resource decision point tool. Another resource decision tool is, of course, the service-centric measure, where we say we're doing all these tests, what percentage of it can we reduce because they're being used on inappropriate patients? So the results from the literature. So people have been using like all different types of measures, obviously, because they've chosen what denominator they've been using based on their research question. So at the start of my PhD, I was looking at what other people had been doing and started trying to compare them. And then I realized, okay, well, I need 3 different graphs here. I've only got 2 here, but to actually say, well, we can put all these ones with the percentage of patients who had the potential to receive low-value care here. And then on this axis, we've got the percentage of services that were potentially used in a low-value way. So again, if you're trying to compare your results to an international study, you've got to think, where do you want to fit? And then our PC indication measures, just as a quick plug, got picked up in the Right Care Lancet series, the evidence for overuse of medical services around the world. So thank you. Thanks for coming today, and yes, had a great day. Thanks.